Hello, everyone. Good morning, good afternoon, and good evening, whatever you're joining us from. My name is Ibrahim Omar, and I am a TPS member. And today I'm very happy to be introducing today's TP Recap episode. I'll be joined by my friends Manahil, Rahul, as well as Masa. They'll be presenting awesome presentations today that I just got a look on very briefly prior to the session. And without further ado, Manahal, if you'd like to unmute and introduce yourself and then share your presentation with us.
Hello everyone, I am Minahil, IMG from the Pakistan, and I will be doing teaching points today. Let me share my screen. Okay, I will be doing the teaching point recaps of a case from Fab 6 that was presented by Baha and discussed by Ravi and Ibrahim. So it's a story of 62-year-old male who presented with the complaints of fatigue despite enough sleep, daytime somnolence, and weight loss. So here we have fatigue and weight loss as non-specific symptoms. Now we have to differentiate between the fatigue and the weakness. So how we will differentiate between them? At first, we will conduct a basic hour examination to look for their strength. In the weakness, you will find reduced strength and fatigue that will be normal. There will be muscular atrophy, fasciculation, reflex changes in the weakness. And if the patient presents with fatigue, that patient will have sleep disturbance, mood changes, and shortness of breath. Usually the cause for the weakness are neuromuscular and metabolic. For fatigue, it's usually systemic, psychiatry, and inflammatory. Now, if the patient rests, weakness usually doesn't improve, but fatigues do improve with rest. Then further, we have to differentiate the fatigue. Patient is having fatigue at the rest or with exertion. That will give us a great clue on that what system is affected. If the patient have a fatigue at the rest, then we have to think of metabolic and systemic causes that can be kidney or any liver disease. If patient have fatigue with exertion, then cardiopulmonary is the most usual cause. Moving further towards the history, he presented with 2-week history of pruritus, especially at night. He have pale stool and abdominal pain, and he also complains of bloating after eating the fatty food. So pruritus is not always a dermatological issue. It can be a symptom of systemic diseases like lymphoma. Now I will highlight 3 important presentations, that is pruritus, abdominal pain, and pale stool. So in this case, no misdiagnosis will be liver pathology. We have to consider that in mind. Moving towards the vitals that were within normal limits. In examination, he was appearing icterus. On abdominal examination, there was tenderness in the right upper quadrant and left upper quadrant. Neurological examination, there was no deficit, but there was a slight muscle weakness, and the rest of the examination was normal. So why patient have the pain in the right upper quadrant? That is liver related. So the main cause is that it is not due to the liver itself, but it is due to the stretch of the liver capsule. Now, what can be the causes of the stretch of the liver capsule? It can be biliary outflow obstruction, venous outflow obstruction, or any mass that is causing the distension of the capsule. Then muscle wasting, which we found in a neurological examination, it suggests that a patient have a chronic disease process rather than an acute condition. In the labs, the CBC, we have WBC is 3140, platelets were 115,000. Liver panel AST was 59, ALT was within normal limits, ALP was 210, bilirubin was 1.9, and GGT was 442. So here we have like what's the association between pancytopenia and liver abnormalities. So I will do my best to make it understandable, like consider it as a portal vein, and this is the bile duct. So this bile duct when become fibrous, this will compress this portal vein. that will lead to the portal hypertension and non-cirrhotic portal hypertension. So due to this portal hypertension, it will result in the splenomegaly that will lead to the increase in the sequestration and destruction of the blood cells. And as a result, we have pancytopenia. And this splenomegaly will also explain why patients have a pain in left upper quadrant. Next, we have to differentiate that whether patient have extrahepatic or intrahepatic pathology. So we will take two things in consideration. What's the mental status and what's the value of the AST? In extrahepatic disease, patient is usually like normal, they will not be confused. But in the case of intrahepatic cases, patient will have altered mental status. Then second clue that will help to differentiate will be AST. AST in extrahepatic disease will be mildly or like normal levels, but in the intrahepatic, we have a highly elevated AST levels. Moving towards the patient's ultrasound imaging, it shows hepatomegaly, irregular liver control, increased echogenicity, intrahepatic ducts not dilated, and no stone in the gallbladder. Going towards the autoimmune panel, ANA antibodies, liver and kidney microsome antibodies, and small muscle antibodies were negative, but antimitochondrial antibody was positive. So antimitochondrial antibodies are positive in two conditions, that is primary biliary cholangitis and autoimmune hepatitis. So as we discussed before, like primary biliary cholangitis is responsible for the portal hypertension without the cirrhosis. So it is leading to this, all the fibrosis and inflammation that will lead to the compression and causes this portal pressure. I will summarize this case. So it's a story of 62-year-old male, presents with fatigue, weight loss, pruritus for 2 weeks, pale stool and abdominal pain. On examination, there was icterus, tenderness in the right upper quadrant and left upper quadrant. In labs, we have pancytopenia, ALT and GGT was elevated, and AMA and antibodies were positive. So this patient was diagnosed with primary biliary cholangitis. I will just give a brief review of the pathology and prognosis. So like what's the pathogenesis of PBCs? So there are like two factors. One is genetic and next is environmental trigger that will lead to the bile duct epithelial injury. So these two processes will activate innate and adaptive immune response, causing the portal inflammation and bile duct damage. How does this disease progress? Once immune-mediated bile duct injury occurs, chronic cholestasis drives ongoing inflammation and scarring that will lead to the disease progression. So these are my references. Thank you, everyone.
Thank you, Manaho, for the awesome presentation. So I think there was a question that was posted in the chat throughout the session, which basically asked, do you know if there's any specificity for pruritus at night that this patient initially presented with?
As for I can like comment on it, like it's a non-specific, like not related to the timeline. Do you have any thoughts on this, Ibrahim?
I don't. Unless anyone has any other thoughts or questions, we could move to our next presenter for today. And that will be Masa. By the way, Manahal, I would highly suggest taking a look at the chat and seeing how everyone is hyping you up. So, Masa, if you feel comfortable unmuting and introducing yourself, and then we can go ahead with your presentation as well.
Hey everyone, I'm Marcel. Let me share my screen. Okay. Okay, so I will talk about a case that was presented by our lovely Academy member, Sosan. So this was a case of a 32-year-old female who presented with colicky right upper quadrant abdominal pain of 4 days, fever of 38.5 degrees Celsius, and yellow discoloration of her skin for 1 day. She has pale stools, dark urine, and pruritus. Her white count was elevated, and she had elevation in her liver function tests, and ultrasound showed CBD dilatation. So this patient had yellow discoloration of the sclera. So at what level of bilirubin do you think jaundice becomes clinically apparent? Oh, I ruined it for you guys. It's 2.2 to 2.5. So normal bilirubin is less than 1.2, and but it won't show up until it's elevated to 2.5, and it usually has higher affinity to the sclera, but can also show up on the mucous membranes pretty early on. Anyway, so this is just a recap of bilirubin metabolism, so we can go over jaundice, and it makes it a little bit easier. So as we all know, bilirubin is a breakdown product of hemoglobin, and here it is unconjugated bilirubin. And then it goes to the liver because this is fat soluble, and the body needs to turn it into water soluble form so it can be excreted in the urine. So it goes to the liver as unconjugated bilirubin, and then it gets conjugated into this water soluble form, which then gets secreted into the intestines. And here it gets oxidized by the bacteria into urobilinogens, and this urobilinogen either gets reabsorbed back into the enterohepatic circulation or gets excreted in the urine, and that's what gives urine the dark color, or like its color, its normal usual color. And or it can like change to stercobilin, which is what is excreted in the stool and what gives stool the dark color. So now that we know what unconjugated and conjugated bilirubin is, it can help us break down jaundice. But first of all, we have to rule out any life-threatening causes, and those include cholangitis, which will present as right upper quadrant pain, fever, and jaundice. We have to rule out acute liver failure or decompensated cirrhosis, which presents as jaundice and encephalopathy, and any hemolysis. So when we think of jaundice, we think of hyperbilirubinemia and divide it into indirect and direct. So indirect or unconjugated hyperbilirubinemia is elevation of the bilirubin before it becomes conjugated, so before it gets into the liver. So either due to impaired hepatic uptake, like heart failure due to congestive hepatopathy, or increased bilirubin production, like in hemolysis or hematoma, or if there's impaired conjugation, like in Gilbert's disease. And then direct or conjugated hyperbilirubinemia can be divided into either intrahepatic, involving the hepatocytes or the microscopic ducts, and extrahepatic, involving the macroscopic ducts. So why are liver function tests important? So we need them to either investigate patients with suspected liver disease, to monitor patients with confirmed liver disease, or to monitor the effects of potentially hepatotoxic medications. Now, 8% of the general population actually have elevated liver function tests, and these can be transient and without symptoms, and can go down to normal after 3 weeks. And in a recent hepatology VMR, Professor Sundarup actually mentioned that liver function test is not a really accurate name for them, because they don't necessarily reflect the function of the liver, but rather pinpoint to the problem in the liver, like the area where the liver is damaged. To assess synthetic liver functions, we can use albumin or PT-INR. Albumin is a non-specific marker of synthetic liver function, and it's basically a protein that's synthesized in the liver, and it maintains osmotic pressure. Its half-life is 20 days, so it takes a bit of time to decrease. If liver function is normal and albumin is low, we think of things like poor protein intake, like malnutrition in kwashiorkor, or protein loss, like in nephrotic syndrome, malabsorption, or protein losing enteropathy. Albumin is also a negative phase reactant, so it can be low in inflammation. For PT, this measures the conversion from prothrombin to thrombin, and basically we have the intrinsic factors. The vitamin K dependent clotting factors are synthesized in the liver, which are factors 2, 5, 7, and 9. And if these are not synthesized, then PT will be elevated or prolonged. If liver function is normal but coagulation is delayed, then we think of things like warfarin or consumptive coagulopathy or a vitamin K deficiency. So let's talk about ALT and AST. So at baseline, males actually have a higher ALT and AST than females. And in both of them, they can be 40 to 50% more elevated in metabolic syndrome and all its components like central obesity, hyperglycemia, low LDL, hypertension, and hypertriglyceridemia. But they're usually more elevated in ALT, but can be seen in both. So ALT is found in hepatocytes, and it can actually be 20% lower in those who exercise regularly. And ALT can also be falsely elevated after you take a meal. So so wait a bit after someone eats to measure their ALT. And then for AST can be found in other organs as well. And so it can be elevated in non-hepatic causes, and it is not as sensitive and specific as ALT. So for ALP and GGT, ALP is found in bile, canaliculi, bone, intestine, and placenta, and it's actually elevated in smoking, but can decrease after smoking cessation by 1 to 2 months. There is a condition that causes isolated elevation in ALP, and it's known as benign transient hyperphosphatemia, and this is basically seen in infants, in pregnancy, and can also be seen in concurrent GI infections. But this is a transient elevation and will usually normalize after 6 to 8 weeks. And for GGT, this is found in high absorptive or secretory cells, so like the kidney, pancreas, intestine, and so on. And this is actually more specific to bile ducts when it's elevated with ALP. And it is more sensitive for obstructive liver disease. It actually can be elevated by 12-fold in obstructive liver disease compared to ALP, which can be elevated by 3-fold. So elevation in which enzymes do you guys think reflect hepatocellular pattern? Okay, so it is AST and ALT. So AST and ALT elevation can indicate a hepatocellular injury. So we can either divide the causes by ALT predominant or AST predominant. So things that can cause an ALT predominant picture would be hepatitis, like viral, ischemic, autoimmune, or NASH, or acute Budd-Chiari. And things that would cause an AST predominant picture would be alcoholic hepatitis. So the ratio of AST to ALT is more than 2. Cirrhosis, and non-hepatic causes like hemolysis, myopathy, thyroid disease, or strenuous exercise. Both hyper and hypothyroidism can cause AST predominant elevation. So elevation in which enzymes would reflect a cholestatic pattern? Yeah, so it is ALP and GGT. So what is cholestasis? It is interruption in the bile flow from the hepatocyte all the way down to the small intestine. So anything that's interrupting this blood flow would cause cholestasis. So if there is elevation of ALP with elevation of GGT, we think of either intrahepatic or extrahepatic causes. So intrahepatic include PBC, DILI, TPN-associated cholestasis. This is because of inflammatory markers. It can affect bile flow. And congestive, no, not the TPN, I meant sepsis with the inflammatory markers can interrupt bile flow, and congestive hepatopathy. For extrahepatic causes, we have gallstones, cholangitis, bile duct strictures, and pancreatic cancer. However, if ALP is elevated with a normal GGT, we think of some bone disorders and chronic renal disease. Now, we can also use the R ratio to differentiate between hepatocellular cholestatic and cholestatic liver disease, but we can also have a mixed picture. So the R ratio is the patient's ALT divided by the upper limit of ALT divided by the patient's ALP over the upper limit of ALP. Some causes of mixed hepatocellular and cholestatic disease include DILI, like antibiotics, most commonly amoxicillin clavulanate, viral hepatitis, shock liver, and infiltrative disease like sarcoid, lymphoma, and so on. So going back to the patient, this patient had elevated LFTs with ALP and GGT predominance. So here we're thinking of a cholestatic injury, and here the patient was diagnosed with acute cholangitis. So just very, very briefly, acute cholangitis presents with fever, abdominal pain, and jaundice, and that's Charcot's triad. And if there's also altered mental status and hypotension, that would be Raynaud's pentad, and it would indicate sepsis. Acute cholangitis is infection of the biliary tree because of obstruction that causes a stagnant bile and bacterial overgrowth, especially these gram-negative organisms. And the most common cause, as we know, is CBD stones, but can also be due to biliary strictures, malignancy, post-ERCP complication, biliary stents because of infection of the instruments, and certain parasites. So just some take-home points. So AST and ALT elevations indicate a hepatocellular injury, while ALP and GGT elevations indicate cholestatic injury. Albumin and PT-INR serve as markers of hepatic synthetic function, reflecting the liver's ability to produce proteins and clotting factors. And ALT and AST can be elevated in metabolic syndrome or strenuous exercise, so they don't always indicate a liver injury. And ALP can also be falsely elevated after a meal, and the absence of GGT can indicate bone disease. So thank you so much.
Thank you, Muscle, for this awesome presentation. I think it's like a recap of the GI system as a whole. So thank you so much for this presentation. We'll be moving on to our last presenter for today. And so Rahul, if you'd like to introduce yourself and then share your screen and we can get started.
Thank you so much, Ibrahim, for this opportunity. Hi, good morning, good afternoon, good evening. I'm Rahul. I'm a medical graduate from Hyderabad, India. I'm so happy and excited to share my teaching points where Noah presented this case. Let me share my screen. I hope you all can see my screen. Yeah, so this was a case where Noah presented on 20th February, where Rabia and Marcella discussed this case. And I personally felt this is one of the challenging case in real time to identify, the exact etiology and make the diagnostic progress. And here is a chief complaint where the patient is a 30-year-old female with past medical history of heart failure with reduced ejection fraction and systemic lupus erythematosus, and complicated by end-stage renal disease, where the patient received a renal transplant 2 months prior to the actual presentation, where she presented to the ER with the fever for 1 week. Whenever we hear a fever for 1 week as an isolated phenomenon, we have a fantastic mnemonic, right? I made mnemonic where you think of infections, any malignancies, autoimmune etiologies, or drug-induced fever, or any endocrinopathies like hyperthyroidism. But whenever there is the complication, the scenario like as lupus with a renal transplant, the center of gravity of the case changes, and we have to do a broader workup to identify the exact etiology of the fever in this patient. And along with the fever, the patient has an associated flu-like symptoms, and all of the patient family has associated flu-like symptoms. And post-transplant, the patient was found to have a donor-specific antibodies, for which, as a part of evaluation, and she got an IVIG, steroids, and thymoglobulin, rituximab, and all the plasmapheresis. And so far, she was fine. And then she came to the ER with a fever of 1 week. And when we are doing the med-reconcile, there is a presence of, she was using mycophenolate mofetil, tacrolimus, prednisolone taper, and Bactrim, like trimethoprim sulfamethoxazole, and she was also on valacyclovir, given there is a CMV positivity from the donor. And physical exam wise, she was looking uncomfortable, but the cardiac exam, abdomen, skin, and everything is benign with no other red flags, and rest of the exam is fine. And unfortunately, she has a white count of 0.9. I mean, look at it's severe neutropenia, and she has severe lymphopenia, and the patient has neutrophil of 0.6%, lymphocytes of 0.1, and hemoglobin of 8.1, and platelet of 69,000, and her baseline platelet count was 150,000. 150,000. And CMPs is sodium and is renal function, liver profile, and everything is apparently fine. Whenever we have this kind of situation, the real time, and Robbie taught us a fantastic illustration. It's important to hunt for the causes, but it's more importantly to save these patients in real time, right? Because of severe neutropenia, and we really don't know what exactly is causing this neutropenia. Is it because of the ongoing immunosuppression, or else any infiltrated any malignancies, or any infective process affecting the bone marrow itself, causing these kind of neutropenia? But we have to we have to go ahead with the big guns like antibiotics, like vancomycin or cefepime, to cover from for the broad spectrum, and also doxycycline for any atypical coverage, and filgrastim, and for the neutropenia. And then we'll start our diagnostic journey, and we have sent the blood cultures, urine cultures, and everything. Apparently, I'm going to share everything, what are the results. But as for the other labs are considered, she has an LDH of 752 and raised ferritin of 10,000, and the next day it was progressed to 16,000. And based on the on the white count on the CBC, it's showing a picture of pancytopenia, and she got the reticulocytes to understand is there any ongoing hemolysis, and there's elevated reticulocytes, and there is an undetectable haptoglobin despite having normal liver function, and the peripheral smear shows a normal no schistocytes. It's unusual, right? We are seeing some kind of elevated reticulocytosis with undetected haptoglobin, which is suggesting of a severe hemolysis, but we are not seeing any kind of cystocytes. And more importantly, we are seeing a raised LDH, which really indicates a cell turnover. It could be from underlying hemolysis or any kind of intramedullary hemolysis, and also from the tissue ischemia. And during the conversation, Ravi really came up with the two important infectious processes where we have to consider in this situation. Those would be hemoparasites like malaria and babesiosis. But it was really unclear what is causing this kind of manifestations. And more importantly, whenever we are discussing about neutropenia, and more about febrile neutropenia, most likely because of chemotherapy itself is going to cause neutropenia, and more importantly, it's going to damage GI surface. It induces mucositis, and that could really invite all the infectious bugs from the intestinal lumen into the bloodstream, and which really makes the patient sick. But here, it's not because of the chemotherapy, that's for sure. And we can imagine, based on the physical exam, she's not that sick looking despite having a severe neutropenia. And more importantly, if you look at the ferritin here, and LDH and pancytopenia, it's revealing like a HLH picture, right? And hemophagocytic lymphohistiocytosis. But it's very early to disclose the diagnosis of HLH. The HLH has very different etiologies: the primary HLH and hereditary causes, and secondary HLH because of the any infectious organisms. But given the tempo of the case, with ongoing transplantation and receiving all the kind of immunosuppression, we can consider HLH, but something we have to keep in back pocket, and we have to hunt for other etiologies. And more importantly, we have sent all infectious workup for this patient, and all the available all the infectious bug, including from virus, HIV, EBV, CMV, BK polyomavirus, which you have to consider in renal transplant patients, and other atypical organisms like Rocky Mountain spotted fever, ehrlichiosis, and heartland Bourbon viruses, and all the fungi organisms, blasto, crypto, cocci, toxo, bartonella, everything apparently came negative. And that was a really challenging situation, this case. And we are considering any infectious pathology, but all other infectious workup came back negative. And because of the ongoing pancytopenia, and with the degree of neutropenia, because the patient is getting better with these empirical management, she got the bone marrow that showed a hypocellular marrow, with evidence without having any blast cells, and cytogenetics for any MDS or any kind of malignancies is negative. Unfortunately, it was fine, but we really don't know what to do. And more importantly, she got the imaging of the pan imaging chest, abdomen, pelvis that showed an in finding which is out of blue. Here, the bilateral renal masses of suggesting of, as per the radiology report, they're suggesting of renal cell carcinoma with a moderate splenomegaly with no lymphadenopathy. And we have to ask this question: is this mass is arising from the native kidneys or from the renal transplanted kidney? And sometimes even transplant patients, the donor patients, they carry a gene, and that could really cause the renal carcinoma, but which was unclear in this during this process. Yeah, so apparently she was improved with the treatment, and unfortunately she readmitted with to the hospital with the similar complaints, and again they initiated the same empirical antibiotic therapy and for the neutropenia. And this time she got splenic biopsy. We are not unsure what's going on, and it's sometimes it's very challenging to either to go to do a bone marrow biopsy, what's a splenic biopsy, because splenic biopsy has got a lot of complications, because once we punctured the splenic capsule, there's a high risk of hemorrhage. But splenic biopsy in this patient showed extramedullary hematopoiesis, and which was unrevealing. And again she got readmitted, and she went home again, came back for the third time, and received anakinra and tolikizumab and rituximab because of the severe ongoing thrombocytopenia. The suspected could be because of ITP. And during this hospital course, she has some, on the further imaging, she got lower lung lobe infiltrates and wedge-shaped splenic infarcts. And based on this, again, she got the PET scan because she got all imaging possible. And now she got the PET scan, which was unrevealing again. It showed a reactive lymph nodes. But during this process, again, the team was very meticulous, and they sent again all the infectious workup. This time, screens showed positive for Bartonella, and it was further confirmed by the PCR testing, and the diagnosis was made invasive Bartonellosis. Now me I wondered, we thought we sent all the infectious workup, right? In the beginning that was apparently negative, and that's how all this test really fools us in the real time. And we have to consider the pretest probability and how they are testing and what kind of method they are testing and how sensitive and how specific in making the actual diagnosis. So today my conversation is all about infections in renal transplant recipients and other differentials of in the considering fever in renal transplant patients or in transplant, and why we have to consider about infections particularly in renal transplant, or it could be any transplant, because it is associated with high morbidity and mortality. And more importantly, as the transplant and more of, we can consider some specific infections which really varies with post the timings. Is it 1 month, is it 3 months, or 6 months, or is it 1 year? And moreover, we have to consider the exposure. Is the patient having a high risk and living in a TB endemic area? Is it having any risk for trypanosoma cruzi or strong lidosis? And what kind of degree of immunosuppression the patient is on? Because you can imagine our patient is on all possible immunosuppressive agents. And now you may wonder, we have sent all the infection workup and we thought of any malignancy, but everything came back negative. And after that spleen, the spleen testing, and for the which was confirmed by the PCR, showed Bartonellosis, right? And now you can imagine how challenging it is, and how the presentations will be very, very subtle, and that will really divert in making the diagnosis. That's the reason making this diagnosis in real time would be more and more difficult. And I just want to add one more point here. And the what kind of immunosuppression agent we are using really plays an important role in kind of specific infection risk. Let's say if the patient is receiving a T cell depleting therapy like anti-thymocyte globulin, that could really increases the risk of opportunistic infection, because like you can imagine, the T cells would play important role in killing all the viral and fungus agents. And we all have all the viral and fungus infections, but we don't get infections, right? Because our T cells are working so meticulously. But in this patient, they're unfortunately not. And other way around, the drugs like sirolimus and everolimus, which target mammalian target of rapamycin, they're associated with other skin and soft tissue infections. Why? Because mTOR is actually responsible for maintaining skin healing and homeostasis. And if you're inhibiting these molecule, that could really, impair the wound healing process and increase the risk of Staphylococcus aureus infections. Yeah. So now we have this patient, before transplant. In this, imagine in this lupus lady, where how you're going to further evaluate for the infections. First of all, we have to consider exposure history, as I mentioned, and does the patient has any pets at home, and is any close contacts and history of prior infections, and making sure the patient got all appropriate CDC recommended vaccination history. Because if the patient don't get any, does not get any appropriate vaccination, it's high time to vaccinate the patient and then go for the transplant. And what are the other, general infections we'll consider before transplant? The infections like CMV cytomegalovirus, herpes simplex virus, Epstein-Barr virus, varicella zoster, HIV, hepatitis B, Hep C, vaccinal virus, syphilis, MTB, toxoplasmosis. These are the broad spectrum. But for the serology for the high-risk individuals like strongyloids, Trypanosoma cruzi, cocci, histoplasmosis, Kirtan once presented a case on strongyloidosis in a patient with severe degree of immunosuppression, and CDC recommends testing for these bugs whenever we have a patient with immunosuppression from any malignancy or any transplant or any underlying this kind of processes, and the patient turned out to be strongly positive, in Keaton's case. And as I mentioned, the possibility of infections and etiology varies with the transplant period. Let me go over through the early post-transplant period, followed by the mid phase, and followed by the late transplant phase. Because most of this transplant patient will be in the hospital, they'll be monitoring for how the transplant is doing and how the graft function is going, and there's high risk of hospital acquired bacterial infections. And moreover, these patients will have the central lines, right, and some kind of Foley's catheters, and those devices will also carry a risk of infection, and they'll be receiving antibiotics, and they'll be receiving all kind of regime that could really increases the risk of C. diff infection. And there's a less likely possibility of fungal infection like candida, and if there's a possibility of any kind of West Nile virus if it is donor derived. But one thing you have to consider in early post transplant period is hospital acquired bacterial infections and any devices mediated infections and C. diff. And what about 1 month to 6 months? Here is the phase where they'll be on a lot of immunosuppressants, like mycophenolate mofetil, and or else any kind of tacrolimus and other immunosuppressive agents. And there's a high risk of occurrence of opportunistic infections. And what organisms we are very worried about? All opportunistic bacteria like Listeria, MTB, and all this kind of bacteria, and CMV and EBV. I'm going to talk about PTLD in my later slides. And what about varicella zoster virus, herpes simplex virus, and opportunistic infection like aspergillosis, cryptococcus. And this patient was apparently she was on bacterium prophylaxis for the PJP. If there's no prophylaxis, a high risk of PJP and evidence presence of toxoplasmosis and Trypanosoma cruzi and strongyloidosis. And all these agents will be having a peak response during the 1 month to 6 months post transplant. And let me go over after 6 months what's going to happen, what kind of infectious organisms we have to worry in this post transplant, which is 6 months. By this time, the patient will be on immunosuppressions and they'll be achieving a stable graft function. Here, the infections are less likely, but we have to consider community acquired infections like any pneumonias, urinary tract infections, any pancreaticobiliary and diverticular and associated infections. So this is the broad range of what are the organisms to consider. One second, I think it got stuck. Yeah, I'm so sorry for the technical issue. And now let's discuss about our original diagnosis of Bartonellosis. And in these slides, in the subsequent talk, I'm going to talk about how about Bartonellosis and how challenging it is to diagnose Bartonellosis in real time. And it's a fastidious gram-negative coccobacilli, which is directly inoculated from cat fleas. And in majority of immunocompetent host, it's going to present as cat's disease, scatch disease, and lymphadenitis. But in immunosuppressed patients, especially in patients with hematopoietic stem cell transplant or solid organ transplant, like in this patient, and it's gonna mediate as granulomatous lesions of visceral organs, and that is the reason why we label these patients as invasive Bartonellosis. And why it is challenging it is to diagnose Bartonellosis, because of the presence of coexistence of post-transplant lymphoproliferative disease, and more importantly, and the efficacies and sensitivity and specificity of each other diagnostic test, and how the patient is going to present. Yeah, so majority of patients present with fever, with lymphadenopathy, but we have to consider, apart from Bartonellosis, we have to consider, as I mentioned, miliary TB, invasive fungal infections, toxoplasmosis, and malignancy. And we have to specifically ask for cat exposure. And patients also have a concurrent EBV viremia and post-transplant lymphoproliferative disease. And I'm going to talk about what exactly is PTLD in my later slides, but the treatment duration varies in immunocompetent versus immunosuppressed host. For immunocompetent host, it's very short course, maybe for 2 weeks, I guess. But for the immunosuppressed, as in this patient, the recommended regime is 6 months to 12 months, approximately one year. And let me go over the challenges in Bartonella testing. When we first ordered the Bartonella, in this patient, it came back negative. But later, the spleen showed presence of Bartonella and PCR showed presence of Bartonella. So it's very important whenever we are ordering these investigations, organisms workup, it's better to know what kind of testing they are doing and how much sensitive and how specific they are in identifying the in the patient body. So tissue and blood culture, because it's very fastidious organism, it's very low sensitive. And PCR, I would say it's very rapid and it's very specific, almost close to 100%. And sometimes serology, they use ELISA method or IF immunofluorescence test, but the downside of IFA testing is they have cross reactivity with other atypical organisms where we cannot rely on this testing. And biopsy, we in the splenic biopsy we got in this patient, we can use Warthin Starry scan that really shows a clumps of extracellular grams negative rods, because it's gram negative bacteria, right? Or L-shaped bacteria with some evidence of necrosis. And immunohistochemistry also play a crucial role. But if you consider biopsy with possible Warthin Starry scan versus immunohistochemistry, IHC IHC has a more sensitivity and specificity. But if you ask me what's the best single test to order for Bartonellosis, I would consider PCR. And in this patient, it was confirmed to PCR only. And now let me cover with the last topic of the session today, which is post-transplant lymphoproliferative disease. So when I started the session on the fever, we have to include all broad variety of infections, but also the malignancy. One of the potential malignancy we have to keep in our differential in any kind of transplant patients, let it be solid organ transplant or hematopoietic stem cell transplant, is post-transplant lymphoproliferative disease. The name suggests it's a kind of lymphoproliferation, like lymphoma-like presentation. It is seen after post-transplant. By the definition, you can see it's an abnormal lymphoid proliferation in any kind of recipients of solid organ or stem cell transplant. So who is driving this PTLD? The two factors, I would say. It is immunosuppression, because the patient has to be on immunosuppression, right? For the normal graft function, but also it is mediated through EBV infection. And these two factors play a crucial role in inducing the tumor, oncogenesis in the pathology of PTLD. And is there only EBV infection causing PTLD or any other infectious organisms? There are a few other organisms like CMV, even hepatitis C virus, human herpes virus would also cause PTLD. But we are going to label those patients as EBV negative PTLD, because EBV is not responsible for lymphoma in those patients, right? So how does the patient presents? It exactly sometimes presents with an ongoing, our patient history. The patient present have lymphoma like, Hodgkin's lymphoma, where we study about B cell symptoms, right? Fever, night sweats, weight loss, lymphadenopathy, hepatosplenomegaly. But apparently, patients with PTLD, post-transplant lymphoproliferative disease, have a higher chance of extranodal involvement. And more importantly, PTLD affects different organs. it can involve the GI tissue. We can label this patient as GI PTLD, or it can involve the graft tissue itself, or CNS or liver PTLD. So based on the involvement, you're going to see the abnormal patterns of the patients. Yeah, so that's what it goes. And I just want to teach you the pathophysiology here. As I mentioned, the patient is on immunosuppression, and the EBV virus, as you learn in your pathology in your for your USMLE steps, it's going to release a lot of molecules like latent membrane protein and EBV antigens, and that could really trigger the oncogenesis. That could really form a lymphoma like lymphomas, and which is also mediated through some genetic mutations. So it's a combination of all these things: immunosuppression with EBV infection and some genetic mutations, and all these accumulated and result in lymphoma-like presentation, which we are going to label that as PTLD, which exactly presents as either infection or malignancy-like pattern. And you may wonder what is the incidence, and what is the incidence in kidney transplant, and this is it's approximately about 0.8 to 2.5. And as the multi-organ transplant goes, there the risk increases. Pancreas, it's almost close to 5%, liver 5.5, heart is around 2 to 8%, and lungs, multi-organ and intestinal transplants, it's close to 20%. And how about hematopoietic stem cell transplants? The patients with haploidentical, where they only have half match, and allogeneic stem cell transplant are highest risk of 20%, and unrelated donors and umbilical cord transplants close to 5 to 10%, and a classic transplant from the match related donors is close to 1 to 3%. And how you're going to diagnose? So again, history, always history. Always ask for transplant history, when the patient got transplant, and how is the patient presenting, and how long after the transplant the patient is presenting. That would really help you in understanding, is it an infectious process, and also for the you have to consider the malignancy too. And more importantly, you have to assess the EBV status. Is the patient is having an EBV positivity or EBV negativity? If the patient is having EBV positivity with ongoing lymphoma like presentation, we can label that as an EBV positive PTLD. As I mentioned, sometimes EBV will be negative, but the genetic mutations will be accumulated, right? And for example, you may know like MYC, BCL2, BCL6, and all these mutations will happen and could result in lymphoma-like presentation. And more importantly, one of the gold standard tests for the PTLD for exactly to assess the EBV zero status is assessing EBV encoded RNA, or you can also do the EBV DNA levels and get the basic labs. CBC sometimes show lymphocytosis, and obviously LDH shows elevated cell count. And based on the involvement, you're going to have different kinds of patterns of chemistry. And get the imaging as we got in this patient: chest, abdomen, and pelvis, and also get them look for hepatosplenomegaly or lymphadenopathy, and get a PET scan, PET CT to assess for any focal nodularity, any focal reactive processes. And then once you're sure about this, and get the biopsy, and then grade it. I think I did not put the slide about the WHO grading here, but the WHO has classified PTLD into 4 different classes, like monophasic, polyphasic, non-destructive, and you can grade according to the histological findings, and more importantly, get the flow cytometry. For example, imagine if the patient is having a lymphoma, EBV mediated lymphoma, where you're going to have specific CD markers, right? If the patient is having an EBV negative PTLD, and they're going and it exactly behaves like a diffuse large B-cell lymphoma, and it's going to have its own specific CD markers. In that scenario, flow cytometry will really help us in making the best guess, and also get the genetic testing. As I mentioned, if it is EBV positive, that's fine, and we are done. But if it's EBV negative, we have to hunt for the causes. What exactly is driving this lymphoma? Is it MYCG? Is it BCL2? Is it BCL6? And all these workup would be the best. That will finally help us in making the diagnosis of PTLD. And again, this is a table differences between EBV positive PTLD and EBV negative PTLD. Whenever the patient is, if EBV positive, if the EBV virus is driving the lymphoma, they're going to present this very, very early, within less than 1 year. If it's negative PTLD, you can assume probably 2 to 5 years would be the ideal presentation. As I mentioned, the name suggests EBV positive, right? It is driven by the Epstein-Barr virus. But here, It's because it's not because of EBV, it's because of something else. It could be virus like HHV8, it could be from CMV, but more importantly, more likely from the accumulation of all the genetic mutations. And EBV positive PTLD could be monoclonal or polyclonal, but EBV negative PTLD has a worse prognosis. It is monoclonal and exactly behaves like diffuse large B-cell lymphoma. And how you want to treat this patient with EBV positive PTLD? Because remember, the immunosuppression with EBV is driving all the infective all the process, right? Imagine if you reduce the immunosuppression, don't you think the R cytotoxic T cells is going to kill the EBV virus and then helps decrease the lymphoma progression? That could be our best step. And even WHO recommends the same therapy. First of all, reduce the here RIS stands for reduction of immunosuppression. And then, even though the patient does not respond, then you can choose an appropriate response. You can go for any specific immunotherapy or chemotherapy, and more the widely used agent is rituximab. But for the EBV negative, as I mentioned, it exactly behaves like DLBCL, where you have to start with the lymphoma regimen, and usually does not respond to reduction of immunosuppression because it's not the purely about the immunosuppression, it's because of the ongoing genetic mutations driving the PTLD. And here's the management again. You have reduce the immunosuppression first and look for other options like chemotherapy or immunotherapy, and you can give it a try on rituximab. Yeah, these are my references. Thank you so much for listening my presentation patiently.
Thank you, Rahul, for this awesome presentation. And thank you to everyone who had joined us today. I don't see any questions that are posted in the chat. I hope you guys have a wonderful rest of your day. And see you on another TP recap session. Thank you, everyone, and goodbye.